the safety and efficacy was such that the FDA recommended people moving forward with the vaccine and that they would collect more data. The formal approval means that the FDA has determined that the level of data is sufficient to have a formal approval of that vaccine for general use, much like it would for any other drug that receives approval. That has occurred so far for the Pfizer vaccine. I've read a press release today saying that Moderna has submitted its package for consideration of full FDA approval. I don't yet know what the status is of the J&J request for full FDA approval. As part of those submissions, every company must say, we are going to do the following things as part of our ongoing follow-up of these vaccines. And that is something where there's a back and forth between the company and the FDA to make sure there is sufficient and appropriate post-approval monitoring of the drug.
All right, thank you. This question comes from Sarah Seifert. Dr. Badley, do you have any comment on what a good benchmark vaccination rate would be among nursing home and assisted living staff? If not 100%, is there a threshold, say 75% or what, that would provide adequate protection for nursing home residents?
It's an excellent question. And to paraphrase the question is, what level of vaccination is enough? And we've heard terms like herd immunity tossed around from time to time. And to me, the term herd immunity is almost an arbitrary term because we don't yet know what level of protection is required to block the continued spread of the epidemic. As time has gone on, we are acutely aware today with the increased number of cases in our hospital that the level of immunity that we have in our communities today are not sufficient to stop the spread of the pandemic. So I think pragmatically, the more people who can get vaccinated, the better. And I think it is a disservice to presume that a certain proportion is enough. I personally believe that everybody who can receive the vaccine should receive the vaccine, and that will give us as society the maximum likelihood to stop the spread of this pandemic, and us as individuals the maximum protection against the severe outcomes of COVID, which are possible, of severe illness, hospitalization, and death.
Excellent, thank you. This comes from Danny Smith with News 19 in La Crosse. Children's cases are higher right now. What's your reaction to this and your directive for parents as kids go back to school?
It's an excellent point, and it's a true point. We are seeing more and more children becoming infected with the SARS-CoV-2 virus. It remains the case that the majority of those infections are asymptomatic, which is the good news. The minority of children who are infected require hospitalization, and that's unfortunate. But it is reassuring that most of them do very, very well. The studies of the efficacy of the various vaccines out there in children under the age of 12 are ongoing. We are anxious to see the readouts of those trials. And once those readouts are available, I'm hopeful that an EUA will be issued for the use of those vaccines in children. The advice I'd give to parents right now with their children, especially as there will be more and more times for children to come in contact with others as school starts to begin, is to, number one, monitor your child's health. And if there is any sign or suggestion of symptoms, to have them tested and quarantined so that they cannot spread the virus to other people at school. And we'll certainly hope and encourage that if all parents do that, we can reduce the rate of transmission that occurs in schools. And number two, to try to keep children away from those areas which have a high likelihood of spread. And we all know what those are. Those are large congregate settings where a lot of people are present. And so for now, we need to return to a degree of caution like we did early in the epidemic, of maintaining a degree of social distancing and masking and frequent hand washing.
All right, thank you. This question comes from Robin Abray. With employer mandates, what are acceptable contraindications or health exemptions from a doctor? Would an antibody test with proof of prior infection be an acceptable exemption with a doctor's note?
Great question. So what is an appropriate exemption to overcome an employer mandate for being vaccinated? I think the answer to that question is employer specific. The question that was specifically asked is proof of prior infection a sufficient reason to not get the vaccine? And the science is clear on that. Immunity that occurs after infection is not as good as immunity that occurs after vaccine. And there's a reason for that. The SARS-CoV-2 virus contains proteins that suppress the immune system. So when you get a natural infection, you're not only exposed to the spike protein, which is the basis of those vaccines, but you're also exposed to that immunosuppressive protein. So the quantitative and qualitative levels of the immune response to natural infection are inferior to the quantitative and qualitative levels of protection that occurs after a vaccine. That is the reason that for 6 or more months, we as a medical community and CDC has recommended a vaccine to occur after recovery from natural infection.
All right, thank you. This comes from Tom Guisto from ABC News. Hopefully I didn't butcher your last name, Tom. Do you recommend that people get a third booster shot at this time?
So a third booster shot is not possible at this time for most individuals. The rollout of that third booster shot is going to occur mid to end of September. And I believe the date is September 20th, but I'm not certain about that. And so for most people, it's not possible to get one now. So for that reason, I would not recommend getting one now. For those patients who have underlying conditions that render their immune system less likely to respond to a vaccine than somebody without those conditions, populations which we call immunocompromised hosts, you can get a third dose now, and I and Mayo are recommending those people get their booster shot now.
All right, thank you. This comes from Glenn Howitt from the Star Tribune. Is there a difference in the profile of patients who are being admitted to the hospital at this stage of the pandemic compared to 1 year ago? And also, are they staying in the hospital for shorter stays?
Excellent question. So broadly speaking, the majority of patients who we are seeing get admitted to the Mayo hospitals fall into one of two categories. Category number one is those who have chosen not to get vaccinated. Category number two are those individuals who we were just talking about, who have impaired immune systems and thus are less able to respond to the vaccines. That is the overwhelming majority of people who are admitted to hospitals across the Mayo enterprise. In terms of their length of stay and their outcome, I don't have data to compare length of stay and outcome today versus a year ago, but it is my belief that the length of stay is similar to what it was a year ago.
All right, thank you. From Tyler Job with WKBT News 8 Now in La Crosse, do you think the FDA's full approval of the Pfizer vaccine will change the minds of those who are hesitant about the vaccine?
I certainly hope so. When I have spoken to individuals who are hesitant about the vaccine, my approach has been to ask specifics as to what is the basis of that hesitancy. And the most common answers I hear are, it hasn't been studied long enough. It was rushed. And my response has always been and remains that while there were parts of the vaccine trials that were rushed, there were parts that were not rushed. And the parts that were rushed were essentially the paperwork parts. So whenever you apply to do a clinical trial of anything, you have to submit a lot of paperwork to get what's called an IND. In my experience as a clinical investigator, and I've done clinical trials for 25 years or more, the turnaround time for those requests is months, often a year. What was sped up in the COVID era for the COVID vaccines is those IND requests were acted upon within days to weeks. So that is the part that was rapidly accelerated. The enrollment of patients, the follow-up of patients, and the stringency of patient follow-up was not rushed in any way. And in fact, we have vastly more clinical experience with the COVID vaccines today, wherein hundreds of millions of people have received these vaccines. We have more data on these vaccines than practically any other vaccine in history. So the quality and depth of understanding of the risks associated with this vaccine are excellent, are very, very well known. So with this approval, will it increase the likelihood that some people who are hesitant in the past will get the vaccine? I certainly hope so. This is the gold level standard of a safe and well-tolerated and effective vaccine, and we now have that. So I'd encourage everyone to go out and get their vaccine if they haven't done it already.
Great point. I can't imagine another time in history where we've had so many eager study participants. So, okay, this question comes from Carly Petrus from KTTC in Rochester. When vaccine boosters are available for everyone, do you recommend them? And is there a plan in place to get those to everyone who wants one?
So would I recommend one? Yes. I think the quality and level of the science is clear and consistent, and every group that has looked at this question has had the same finding. Immunity tends to wane over time, and a booster vaccine increases that level of immunity. So I think that the data are very, very clear. Would I take one? Absolutely, I'd take one, and I would absolutely recommend for all of my friends and loved ones to take one, and so I'd recommend it for the general public. Are there plans in place to create the supply chain and the distribution path to make these available for everyone? Absolutely. There are state-by-state specific plans for distribution. I can assure you that Mayo will have a role in this, as we did with the initial phase of vaccination, and we are making plans already to be ready for that when the third dose is available broadly.
Do you anticipate that rollout will be much like the first one, where we have first responders and healthcare providers and elderly and so on? Is that kind of a thought?
So I don't know is the honest answer. The recommendation is likely to be that the booster shot occurs 8-ish months after the second dose. And so because there was a different time in the spring when everybody reached their second dose, there will be a 8-month delay in that. So there should be a stagger built into the system. So if you're coming up to your 8-month anniversary of your second dose, absolutely contact your healthcare provider, your clinic, your hospital, and find out the best way to get your booster shot.
All right. Follow-up question from Carly here. Do you think boosters underscore the vaccine, perhaps the need for the vaccine? I'm not exactly sure.
Yeah, I'm not sure what the question is driving at, but the concept of a booster is not a new concept. We get booster shots for lots of other vaccines. We get booster shots for tetanus. We get booster shots for pneumococcus. We get booster shots for lots of different vaccines. And the reason we do that is a natural part of immunity, in that the levels of immunity that are circulating in people tends to decline over time, and a additional shot, otherwise known as a booster, will augment that. The rate at which different levels of protective immunity decline appear to differ between different vaccines. And rather than saying that, we're going to need a booster shot every 8 months or something from the COVID vaccine, I think where we are right now is to change our thinking and understand that a complete course of COVID vaccine consists of 3 shots. 1 shot, another shot a month later or 3 weeks later, according to the vaccine, and another shot 8 months later. And that together consists of a full course of vaccination, and the durability of that full course remains to be determined. But I'm optimistic that that is going to have a very durable protective window.
All right. Thank you. Follow-up question from Tyler from WKBT. As school starts, you mentioned kids should stay away from crowded spaces. What if they're playing in sports where physical contact is inevitable?
So I would not prevent my children, although my children are not of that age group now, but if they were in that age group, I would not prevent them from playing in sports if they didn't have chronic medical illnesses that impaired their immune systems. But what I would do is I would monitor them very, very closely for the development of symptoms. And as we say, if they have symptomatic disease, test frequently and often, and isolate if positive to prevent spread to others.
And what about 12 and up?
12 and up, get the vaccine.
That was a prompt. Okay. This comes from Tom Guisto again from ABC News. Dr. Badley, would you take a cruise now? And what is your advice to your patients who want to take a cruise?
So I've taken 1 cruise in my life, so it is unlikely that now I would take a second one. And it's not that I have anything against cruises, it's just not that I do those often. What would be my advice to somebody who wants to take a cruise? It would be very individualized, as my advice would be to any patient about any question. Do they have chronic immunosuppressive conditions? Do they have conditions that would increase their likelihood of a bad outcome if they got SARS-CoV-2? Have they been vaccinated? Who are their loved ones in their home? Is there somebody at especially high risk for bad outcome from COVID, et cetera? And all of those factors would weigh into the advice that we'd give. I think it is fine to vacation. I hope to have a vacation very, very soon myself. But I think the kinds of vacations we should be doing now should be thoughtful and try to avoid large congregate settings. And if you have individuals who you're planning to vacation with, who have underlying medical conditions, I think your itinerary might be best modified to reduce the likelihood of high-risk exposure.
Very good. Can you talk about your guidance surrounding large outdoor gatherings such as fairs, festivals, concerts for fully vaccinated people?
Yeah, so again, my advice would be tailored by the individual, much as we just said previously. I assume that question has a relation to the state fair, which is coming up very, very soon, and that's a good thing. Neither I nor Mayo will advise on whether or not it's a good thing to go to the state fair or not, but I think it is appropriate to do tailored risk benefit analysis like we just talked about. If you have an underlying immune suppressive condition that makes you unlikely to respond to the vaccine, or you're unvaccinated, or you have a high risk for serious complications from COVID, my advice to a friend or a loved one would be not to put yourself in situations where there's a high risk of exposure.
Excellent, thank you. I'm just making sure I've got questions that I haven't missed any. Okay, this one's about supply. In your estimation, when we get to the point of administering those 3rd shots or those booster shots, any concerns about supply, adequate supply?
Great question, and 2 answers for that. So do I have concerns? Of course I have concerns. Do I have any knowledge that is different than your knowledge? No, I don't. I don't know what the supply chain is like. I do know that the vaccine manufacturers would have liked to have produced vaccine more quickly than they were able to do in the spring. And I am certain they have done what they can do to ramp up production. So I have concerns that the supply might not be as robust as we want. I have no inside knowledge that it is or is not. And I just encourage people to get the vaccine when they're eligible. If we run into a problem, we'll run into a problem and we'll tackle it then.
All right, thank you. So questions are slowing down. We have about 25 minutes left. I would welcome the journalists to keep your questions coming in the chat, or I think at this time it'd be fine if you wanted to unmute yourselves and speak with Dr. Badley directly. I'll get us started.
Hey, Dr. Badley, it's Tom Gista with ABC News. Can you hear me?
I hear you well, thank you.
And thank you.
So, where I live, by the Mayo Clinic in Florida, mask mandates in schools is a big deal. What's your position on whether school children should have to wear masks in class?
So as a physician, I give advice to individuals. I don't advise on public policy. And as a physician, if I were to give advice to an individual, I would consider all of the factors that we've talked about in several questions now about individual risk factors. I personally wear a mask when I go into a grocery store or a shopping mall because I do not want to be exposed to SARS-CoV-2. I don't want to have to be quarantined and limit my work if I were to get an infection. And those are all the considerations that go into a personal decision of whether you make a mask or not. Public health officials have a much more difficult task. And I'll bring it back to the personal level that as you're deciding whether to wear a mask or not, personal risks and potential outcomes from an exposure and or an infection need to be considered.
Would you want your child to wear a mask in the classroom?
I would probably recommend my child wear a mask.
Thank you.
All right, other journalists? Dr. Badley, one question just for fodder is, I've heard a lot about personal choice and medical freedom. And I've got, I think all of us have friends or people we know who are, saying things like that, maybe opposed to the vaccine, maybe reluctant. Is this one of those situations where our personal freedom needs to be in a back seat for the greater good?
Thank you for that easy one. I mean, it's a difficult question. So, the rights of individuals and the principles of autonomy remain intact and robust. But there are circumstances in healthcare where healthcare interventions can be mandated when those interventions can impact public health. For example, if I have active tuberculosis today, or 2 years ago, or 5 years ago, and it was diagnosed, public health would be informed, number one. And number two, I would be asked to take my medicines. If I did not take my medicines, public health could intervene and restrict my freedoms. Why? Because the risk of spreading tuberculosis to others is a big cost to society. So there are precedents in terms of risk to society versus personal autonomy. Similarly, there are examples where employers can mandate certain health interventions, and that can be flu vaccine, TB testing, etc. This is clearly an area where those two issues are coalescing. And we're seeing that different industries and different workplaces are working that calculus differently. At Mayo Clinic, what we have done is we have left it voluntary whether or not you get a vaccine, but we have created a formalized process to opt out of that vaccine. And that formalized process includes a certain reason for opting out of the vaccine and an education component associated with that. Now, is Mayo's position going to change over time? I don't know. I know that it is constantly reevaluated, but as of today, that active declination process is the policy that's in place.
All right, thank you. All right, we have a few more questions here in the chat. Are the types of masks important? How much protection does a cloth mask really provide if everyone around you, schools without mask mandates, for example, aren't wearing one?
Yeah, so absolutely the type of mask does matter, and the fit of the mask does matter. A year or so ago, there were a lot of scientific papers that addressed that issue, and that remains clear. But comparing no mask to any mask, the protection of any mask is superior to the protection of no mask. So I do think there is a benefit to wearing a cloth mask, again, provided it fits well.
All right, thank you. This question from Jason from KAUS Austin. Do you think we will ever reach the point of herd immunity with COVID, or is the virus mutating too often for that to happen?
So there's two questions implicit in that. So question number one is, do I think we'll ever get to a level of herd immunity? And that really has to do with what the definition of herd immunity is. Do I think we'll ever get to a level whereby the level of immunity in the community is sufficient to prevent ongoing high-level transmission? Yes, I think we can get there. That having been said, I think we will continue to see sporadic cases of SARS-CoV-2 infection and COVID disease for months to years in the future. But hopefully we'll get to a point whereby it doesn't have the high rate of hospitalization that we're seeing now. The second question is the virus mutating too often? The virus is mutating every day. The longer that you have virus replicating within a person or a population, the more viral mutants you're going to see. And it's an evolutionary battle between, are these mutations creating a survival advantage for the virus, or are they hurting the virus? So viral mutations are occurring. They will continue to occur. So far, we've been very, very lucky in that the vaccine-induced protection has covered all of the variants that we're aware of. The more that viral replication occurs, more mutations will come up. Will they one day escape the vaccine? There's no evidence that that's going to happen, but it's something we have to keep very active surveillance from. And so multiple places, Mayo Clinic a little bit, the state health department a lot, and the federal government a lot, continues to monitor what variants are out there and to what degree do the vaccines protect against those variants.
Thank you. Can you speak a little bit about the variants and like what's coming up, coming down the pike? We hear about Lambda a little bit. What do we know? What do we know about Delta that's different than the original virus?
Yeah, so as we mentioned, that every time the virus replicates, there is the potential for a mutation. The more episodes of viral replication, the more episodes of viral mutation. And then it's an evolutionary gain. Do these mutations confer a advantage to the virus, or do they hurt the virus? Most mutations hurt the virus, and so those mutant viruses go away. A very small number of these mutants confer a survival advantage for the virus. For example, one of the initial mutants allowed the viruses to infect cells more readily. And that was one of the first mutants that we saw. Over time, more and more mutations accumulate. And so as we went through the different strains of variants that we've seen, accumulation was the creation of the emergence of the Delta variant, which has about 4 or 5 different mutations on them. And together those mutations mean that it infects, that the Delta strain infects more rapidly and causes more illness compared to the initial strain. What will the future strains look like? I have no idea. Time will tell, and that's why it's very, very important to monitor them. What we know about the Lambda variant is that we've seen it, we've identified it, we've sequenced it. We don't know much about its biological behavior now. In part, that's good in that there's no signal yet that it's worse. But as time goes on, we'll get more and more information about the biologic behavior of what Lambda and other future variants do to the infection and to people.
Okay. Thank you. Tyler from WKBT. A lot of people will never get a COVID vaccine. Say, for example, if there aren't enough people vaccinated to achieve herd immunity, at what point do we go on without the masks and social distancing, et cetera?
It's a great question. I don't know when that is. Ultimately, it becomes a personal decision. I think, you know, from an individual perspective, the best things you can do to stop the spread of COVID are 3 things. So one is, if you're exposed or test positive, you isolate to prevent the spread. And we need for more people to do that. Number 2 is, if you're exposed and diagnosed, you seek care quickly. Why? Because if you are treated for COVID, the amount of virus that you shed is less than if you're not treated for COVID. So again, that'll stop the spread. And then the third is, do what you can do to prevent the spread within society, which falls into 2 buckets. 1 is to get the vaccine, and 2 is frequent hand washing, avoidance of congregate groups, etc. And even those people who don't get the vaccine can participate in those other parts. You know, there can be fundamental philosophic objections to the vaccine, and you know, we need to respect that. But that doesn't mean that those people shouldn't get tested, shouldn't get treated earlier, shouldn't wash their hands and isolate if they become infected. And I'm hopeful that as we move down this pandemic, we start to see that we have spikes like we're having one like we are right now, that people will together rise up and take all of those recommendations more seriously, so that we can stop this current surge and really stop COVID in its tracks to get control of this pandemic.
Thank you. So you mentioned the boosters might be mid-September, mid to late September. That strikes me as very similar to the timing of flu shot, where we push for flu shots. So do people need to be aware of spacing out those vaccines, or any vaccines along with the COVID booster or initial vaccine?
Yes, so should you space out the COVID vaccine and the flu vaccine? There's no data to suggest they're better if they're spaced out than if you receive them at the same time. But you bring up a very, very, very important question. And that question is, you know, we're entering the fall now. Are we going to experience what we feared last year, which was the convergence of flu and COVID and RSV? RSV is another virus, stands for respiratory syncytial virus. It causes disease most often in children. We're already starting to see a spike in RSV cases. I think we're going to start to see a spike in influenza cases earlier this year than we've seen in previous years. Last year, with strict social distancing and isolation and some quarantine mandates, we really didn't have much of a flu season. we're concerned that this year we're going to get it. And at its earliest stages, all of these diseases can look very similar. And so it re-emphasizes the need to get the vaccines you can get, which include influenza and COVID right now. There's no good RSV vaccine. So get the vaccinations you can get and seek testing very, very early at the onset of the symptoms. And most hospital systems, I believe, will test for all three of these agents in parallel.
All right, thank you. Very good information. All right, some more questions in the chat. By and large, this comes from Robin. By and large, one argument I've heard over again is that vaccinated people can still get infected and spread the virus. So why would I get vaccinated? Can you please dispel this in lay terms?
Yeah. So yes, we are seeing that vaccinated people can still get infected. That's a true statement. The degree of illness that they get is much less. And associated with that, the amount of virus they have is much less than somebody who is sick. So even though you're infected, you have less virus and you can still spread it, but your risk of spreading it is much less than if you're sick from COVID. Also, when you are diagnosed with it, you can have the added benefits of isolating and quarantining so you don't spread it. But on a population basis, the ability of a vaccinated person to spread COVID is less than the ability of an infected, unvaccinated person.
All right, thank you. The other point that I just was wondering if you could underscore on that is kind of we know that the vaccine does prevent illness, severe illness and death, and kind of who's in the hospital right now, if you could talk to that. And then also, if you could speak to these breakthrough vaccinations and whether or not they're within sort of the expected margin. Can you speak to those things?
So absolutely. So let's talk about the concept of breakthrough infections right now. So I think it is misguided to lump all breakthrough infections together because they're very different according to the groups that you think about. So group number one of so-called breakthrough infections are vaccinated people who, without any symptoms whatsoever, acquire infection and it's diagnosed as part of routine screening. These vaccines were not designed to prevent that infection. These vaccines were designed to prevent hospitalization, severe illness, and death. And they do that very, very well. In a recent study that Mayo was associated with, the amount of death in vaccinated people was 0. So it's very, very, very effective at that. The second kind of breakthrough infection is a vaccinated person getting symptomatic disease and having to be treated. For a vaccine that is 90% effective, which all of these approved vaccines are more or less, you expect to see symptomatic infections in 10% of cases. So the fact that we're seeing some of these vaccinated people get symptomatic disease is expected, and it's exactly how these vaccines should work. The third kind of breakthrough infection are the people we've talked about several times in this call, which are those people with impaired immune systems, and we don't expect those people to respond to the vaccine as well. In fact, that is why they were the first group recommended to have the third booster dose. In those patients, through no fault of their own, they cannot respond to the vaccine as well as your normal host, for lack of a better word. And those are some of the people we're seeing going into hospital now. So the efficacy remains very, very strong. These vaccines are behaving exactly as we expect them to. And what is new over the past few weeks is we now understand that by giving a third dose, or we've called it a booster shot, but I'd encourage us to think of that's still the basis of the primary series of vaccines. These additional shots increase levels of immunity to restore protection back up to what they were soon after receipt of the first series.
Gotcha. Thank you. This comes from Carly. Can you explain how the Lambda variant will compete with the Delta variant? Which variant is more of a concern?
Great question. And the answer is I don't know. And I don't think anyone knows, but time will tell us. So a variant that has a survival advantage is the variant that is going to predominate over time. And right now, the variant that is out there and dominating the cases that we're seeing in Minnesota and everywhere else is the Delta variant. So as of today, the Delta variant is the variant that's of most concern. The Lambda variant's been reported for some number of weeks now. To my understanding, it is not becoming the dominant variant anywhere. If anyone on the call today knows of otherwise, I'd love to know. But the fact that it's not becoming the dominant variant means it is not the most concerning variant right now. That can change. We are likely to see a new variant, and if it becomes a dominant variant, then it is the most important variant of concern.
Excellent. All right, I see one more question in the chat here. I am going to just put out another call for journalists. If you do want to unmute yourselves and ask a question directly, that would be fine. We do have about 7 more minutes before Dr. Badley has to sign off. So here's another question from Robin. Do you think that viral load has something to do with symptomatic breakthrough infections in vaccinated people? So if someone has a job that requires them to be around a lot of people versus a passing interaction with someone who has COVID?
Yeah, so it's an excellent question, and I'll answer it in 2 ways. So the first way I'll answer it is, what do we know based on published studies? So what we know based on published studies is that for every virus for whom this has been studied in the past, the amount of virus correlates with the degree of symptoms and the degree of complications. That's true for HIV, hepatitis B, hepatitis C, and many, many others. In the setting of COVID, the few studies that have been done out there so far are relatively small studies, and they have not yet seen that correlation. So that's what's published. What do I believe? I believe that symptomatic people will have higher viral loads, and I believe that if you have a higher viral load, you're more likely to get sick. Those data haven't yet been published by anyone, but again, that's my belief. So I do think that viral load is very critical for how you as an individual will do, and how you as an individual, how likely you are to transmit the virus to someone else.
All right, thank you. Journalists, if you'd like to unmute and ask your question, I did put, I accidentally copied and pasted the whole thing. What I was intending to paste again was Dr. Badley's bio and title and our email addresses and web addresses for more information and follow-up questions. So feel free to unmute if you'd like to ask Dr. Badley a question. Do you want to speak to Dr. Badley that sometimes people are, obviously not being told if they have Delta, and do they need to know that? And how are we determining if it's Delta or not?
A great question. To paraphrase the question, does it make any difference if an infected person knows what variant they have? And the answer to that question is no. Irrespective of, do you have Alpha, the original strain, or Delta, or in the future Lambda, the treatment approaches and the treatment recommendations remain the same. So on an individual patient basis, there is no difference in the treatment or the treatment recommendation on the basis of what variant you have. How we determine what variant you have is complex lab work, and complex in the sense that it is time consuming and expensive. And because it doesn't make a change in clinical recommendations, we don't do it on every viral variant. So when you're diagnosed, the chance that your variant will be sequenced to determine what it is is very, very low. The importance of it is from a public health perspective. And that's why most of the work is being done at the state health department and the federal health department levels. And that has to do with to predict the spread and to predict the likely trajectory of the number of cases. And that's its biggest importance. So far, there is no evidence that the variants respond differently to any of the treatments. And that's the good news. For other viruses, different variants can respond differently to treatments. For example, in the HIV setting, different variants can be resistant to some of the drugs. Again, that is not happening in COVID. We don't anticipate it will, but if and when it comes, then that will be a reason to do individual variant identification in individual patients.
All right, thank you. Okay, last call for questions, journalists.
Great.
All right, with that, thanks again for your time, Dr. Badley, and thank you, journalists, for joining us. We will have a recording if you should need it. Email us at newsbureau@mayo.edu and we can get you that recording. And thanks again, everybody. Have a great day.
Thanks, Dr. Badley. Take care.
Bye.
Recording stopped. Also, some news to let you know about Tommy Hazuri. We've learned that the city councilman has been admitted into Mayo Clinic. According to a spokesperson, he's been hospitalized with complications from an emergency lung transplant in July of last year. It's unclear what the scope of those complications are. He's been hospitalized. According to a spokesperson, Mayo Clinic admitted into has been into Mayo Clinic. According to a